I've been in the surgical field long enough to recognize the rhythm of the operating room. You prepare, you pause, you listen. Every sponge is accounted for, every clamp tracked, and every scalpel blade registered with the precision that only those of us who thrive under pressure learn to appreciate. This team was seasoned. Dr. Mitchell was the lead surgeon. Our circulator that week was Hannah, a veteran nurse with keen eyes. I was the scrub nurse on a hernia repair scheduled for the mid-afternoon shift. Typically, this kind of case feels routine but still demands the same respect as an emergency surgery. We had set up the Mayo stand. All the instruments were laid out perfectly: scissors, clamps, needle drivers, retractors, and the scalpel handle fitted with a number 15 blade. We double-checked, and our count was accurate. It began subtly. I reached for the Metzenbaum scissors, which I had placed to the left of the scalpel. They were gone. I paused, thinking I might have bumped into them or that Hannah had moved them without notifying me. Upon asking her, she replied, "No," while glancing at the count board. "I haven't touched your area." I checked the back table, finding nothing. The floor was clear, and I even looked under the sterile drape, but there was no sign of them. Eventually, those scissors reappeared under the foot of the gurney, nestled between the frame and the wall, clean and unused, but out of the sterile field. Initially, we attributed it to fatigue. Long hours and back-to-back procedures make it easy to misplace things, but the issue persisted. A week later, during a laparotomy, the Richardson retractor disappeared while we were positioning it. I had placed it just next to the Babcock clamp, but it was missing when I reached for it again. The surgeon joked, "Are you hiding tools now?" We rummaged through the area during our closing count and eventually found it resting under the anesthesia cart. No one had walked there, and the field remained untouched. This shouldn't have happened. Over the subsequent month, it became a pattern. Always one item, always clean, always returned. Not by someone's hand, but by the passage of time. Sometimes it happened mid-procedure, sometimes during the post-op cleanup. We began documenting these occurrences, not for ghost stories, but because even a single missing instrument is a serious matter in the OR, with significant legal and ethical implications. We reviewed the surveillance footage but found nothing suspicious, just empty frames where instruments should have been, then frames where they suddenly reappeared elsewhere. I started to double-check every inch of my setup, positioning each tool thoughtfully and keeping the count sheet close. My stethoscope hung on the hook next to the Pyxis machine. Yet, the strange occurrences persisted, happening maybe once or twice a week. One night, after a particularly intricate bowel resection, I stayed back to help clean up. I was winding down the tubing and removing my gloves when Hannah walked in with a grin. "Looking for this?" she asked, holding up a Kelly clamp, which she had found under the legs of the operating table. We both paused. That was the third time that week. She sat beside me on the stool and said something that resonated with me. "You know, maybe it's not about ghosts. Maybe it's just the room trying to breathe. These walls carry so much pressure, grief, hope, and fear. It has to go somewhere. I'm not sure what to believe. What I do know is this: I've never lost a patient due to a missing tool. I've never failed a count or breached protocol. But I've come to accept that sometimes things move in ways we cannot explain. Tools disappear and reappear, perhaps due to distraction, a trick of the mind in an overworked body, or maybe the room remembers all who have passed through it. And sometimes it shifts just enough to remind you that you're not entirely in control." I was in the on-call room, barely catching my breath between cases. It had already been a long night: 2 intubations, a massive gastrointestinal bleed, and a motorcycle accident. When the pager buzzed, I didn't even flinch. After 19 years in emergency and trauma nursing, you learn to move quickly. We received a level 1 alert for a male patient, 37 years old, with a perforated bowel, suspected internal bleeding, unstable vitals, and a root. O2 was being prepared when I arrived. I washed my hands, tightened my hair, adjusted my goggles, and entered the room. The anesthesiologist was already downstairs, and Dr. Thompson, our trauma surgeon, had just completed a ruptured appendix. The techs rolled in the crash cart and surgical trays while I began the standard inventory. I checked the electrocautery unit, power settings, grounding pad, and suction levels. I adjusted the surgical light arms, checked for patency, and resecured the 20-gauge line with extra tape. No time to lose a line mid-surgery. I prepped the Foley catheter kit and got 4 units of O-negative blood ready just in case. The patient arrived semi-conscious with blood pressure barely stable. EMS had already inserted a 16-gauge line in his left antecubital area, with fluids running wide open. We moved quickly. I transferred leads, set up the pulse oximeter, and adjusted the monitor to split screen for ECG and MAP. He looked pale and diaphoretic. Peritonitis was evident, with a rigid abdomen, shallow breathing, and eyes darting around, trying to stay awake. "Count to 3, the anesthesiologist instructed. Propofol was administered. I added a small dose of fentanyl. Once he was out, I inserted the Foley catheter, draped the field, adjusted the retractors, and double-checked the sterility of the bow tip. We prepped the abdomen with betadine, cleaned from the inside out, and gathered the necessary supplies. That's when I noticed something unusual. It wasn't dramatic. No flickering or shapes above the lights, just a subtle movement. My gaze shifted to the foot of the table. There, at the edge of the sterile field where the monitor cables hung over the pole, stood a figure in a white coat, with older gray hair and arms folded. I didn't speak or react, not out of bravery but to maintain sterile focus. Dr. Thompson was making the midline incision, carefully through the fascia, while I clamped a bleeder and positioned the suction tip. The figure remained still, just watching. I felt a familiar gaze locked on me, and then I heard a voice in my mind. Not aloud, but clear and instructive. "Check the bowel loops. He's bleeding posteriorly fast." I've participated in countless surgeries and knew what to expect, but there was something about that message, the urgency with which it pressed into me. It wasn't my voice or instinct. Taking a chance, I quietly said, "Doctor, could we reposition the retractors posteriorly? There might be deeper bleeding." Dr. Thompson didn't hesitate. He trusted me completely, as always. He nodded and adjusted, leading us to discover a small but rapidly tearing mesenteric artery bleed on the posterior side. He clamped it just in time. Another minute and that man would have gone into cardiac arrest. The surgery went on. We irrigated, checked viability, placed drains, sutured, and documented everything. I was back in my rhythm. By the time we rolled the patient to recovery, his blood pressure had stabilized. He was going to make it. I returned to the operating room to clean up, wiping down the Mayo stand, disposing of sharps, and logging instruments on the count sheet. That's when I spotted it again. A photograph taped to the side of the cabinet, half hidden behind old printouts and QR codes for supply ordering. It was Dr. Samuel Reed, our former trauma chief, who had died in that same or from a cardiac arrest 5 years prior while assisting in a case. A sudden aneurysm, they had said. I'd never worked directly with him, just heard stories. Respected, sharp, methodical. He demanded perfection but trained like a mentor. I had seen that face once or twice on the memorial plaque near the elevators. I wasn't imagining it. I wasn't making it up. I didn't feel cold. I didn't tremble. I didn't shed a tear. I simply stood there, gazed at his picture, and uttered, "Thank you." Then I clocked out. Another life preserved. Not solely through science, not just by our training, but perhaps, simply perhaps, by someone who still valued the work long after their shift had concluded. We had just completed the second procedure of the evening, a routine laparoscopic cholecystectomy. The patient was an elderly woman named Mrs. Clara Simmons, 82, a widow with hypertension and no known drug allergies. Surprisingly, her lab results were stable for someone her age. The preoperative team had prepared her meticulously. For access was achieved on the dorsal side of her left hand using a 20-gauge catheter, and fluids were running, specifically lactated ringers. Her consent had been obtained earlier that morning. I can still hear her gentle, slightly raspy voice as she was wheeled in. "My husband always told me not to be afraid of doctors," she chuckled softly. I smiled behind my mask and squeezed her hand. After nearly 27 years in this field, I've always prioritized being human first. Skills and machines don't matter if you forget the person lying on the table. We followed every procedure carefully. Her airway was managed without issues, intubating her with a cuffed 7.0 ET tube and optimizing the ventilator settings. General anesthesia was maintained with sevoflurane and propofol. Her vitals were monitored continuously on Philips and Teleview screens. The sterile field was set up, and the surgeon, Dr. Stephen Grayson, was someone I trusted completely. Steady hands, no ego. However, around the 45-minute mark, her heart rate began to decline gradually. It wasn't sudden. It crept in slowly. Bradycardia followed by a drop in blood pressure. I immediately checked the 4-line for patency, and it was intact. Anesthesia was already adjusting medications. Atropine, fluids wide open. The crash cart was brought in as we began the ACLS protocol, performing chest compressions and pushing epinephrine every 3 to 5 minutes. Her O2 levels were monitored, remaining low. We worked relentlessly for 35 minutes. Then the silence came. No pulse, no cardiac activity. Time of death was recorded as 1852. I stood still in the quiet room, feeling the unfairness of it all, the way a body loses its fight. Her hand, once warm, was now lifeless. It's never just about death. It's the absence of everything they were. I gently removed the ECG leads, disconnected the 4, and wiped away the gel from her chest where we had placed the defibrillator pads. The pads felt almost disrespectful while still attached, but protocol required their presence until post-mortem documentation was finalized. We cleaned her up with warm saline wipes and draped a fresh, white sheet over her. It was the least we could do to honor her dignity. Later that night, around 22:10, I returned to the operating room, having left my stethoscope, my cherished Littmann Classic III. It had been my companion for years. The room was dim, illuminated only by the soft amber glow of the monitor standby lights against the steel surfaces. There was no movement, just the quiet hum of the air filtration system. As I stepped in, I was taken aback to see her by the door. Clara Simmons, wearing the same hospital gown, her hair perfectly curled as when she arrived. Her hands were folded. She wasn't transparent or floating. She stood there like someone waiting for a restroom to become available. She looked at me, not with malice or a creepy grin, but with an expression of peace. Her lips lifted into a familiar, faint smile, the same one from earlier in the day. I found myself frozen. I didn't run or speak or blink for what felt like an eternity. Then she was gone. Not in a dramatic way. She didn't dissolve or vanish into thin air. She just ceased to be there. I held my stethoscope for a long time, and while my heart wasn't racing, I felt a weight in my chest, as if grief had taken a physical hold inside me. Perhaps it was fatigue or my mind trying to process death. But I know what I saw. I recognize her face. I don't often share this experience. It's not fear of judgment. Rather, the weight of this job is already immense. We are expected to heal, to hold people together with tape and tubing and time. Yet sometimes, the most human thing we can do is witness the ending with gentleness and grace. That night taught me something that I carry into every procedure since. Sometimes the body departs before the soul, and occasionally, they return to say thank you. My name is Sarah. I've always said that the operating room teaches you to expect the unexpected, while also helping you remain calm when it happens. With over 20 years of experience in perioperative services, I've witnessed power outages, malfunctioning suction, monitor failures, and even had a patient's tooth break off during intubation once. However, there's one particular moment that stands out, not for its nature but for the way it felt. It was a routine laparoscopic procedure, an appendectomy. The patient was a young man in his mid-20s, healthy with no remarkable preoperative concerns. His vitals were stable, anesthesia went smoothly, and we had just begun the dissection phase. Dr. Jenkins was the surgeon, known for his steady hands and precision, not much for chatting. The room was silent except for the gentle beeping of the monitor and the occasional exchanges between the scrub nurse and the surgeon. That's when the surgical light above us flickered. Now, our lights aren't your typical ceiling bulbs. They're high-intensity, shadowless surgical LEDs mounted on flexible arms, designed to remain stable regardless of how long the procedure lasts. They undergo thorough checks at the beginning of each shift. If anything seems off, our biomed team takes care of it. Everything had been fine that morning after our checks, yet here we were, mid-procedure, and the light flickered again. It wasn't just once, as if from a power surge. It blinked twice, paused, then flickered again. Not complete darkness, but enough to grab everyone's attention. Dr. Jenkins paused for a moment, not out of fear but assessing the risk. "Check the wiring," he instructed calmly, his eyes still focused on the scope. I nodded and took a step back to look at the control panel. Nothing appeared abnormal. The backup power hadn't engaged, and the room lights were fine. It was solely the surgical light that was misbehaving. Then it flickered once more, and I sensed the scrub tech beside me shift uncomfortably. After years in the field, I recognized that look, half rational, half remembering every strange story we've ever heard in the OR. The reality is, hospital staff don't often discuss these eerie moments, but they stick with us. The sudden cold spots, the empty elevator stopping at odd floors, the patient who speaks to invisible figures before induction, and, occasionally, the flickering light. Everyone in the room was silent. Not scared, just unsettled. So, I did what I typically do in situations like this. I reached up and tapped the metal base of the light, mumbling under my breath, "Not today, spirit." The room didn't chuckle. No one does during surgery. But there was a shift, a collective breath released. The scrub nurse shot me a quick smirk. Dr. Jenkins didn't comment, but I noticed his shoulders relax. After that, the flickering ceased, and the rest of the procedure continued smoothly. There were no complications, and the patient was discharged 3 days later, smiling and walking. Yet, we all remembered that moment. I didn't mean to be funny. It was part habit, part instinct. Nurses have countless rituals, both spoken and unspoken. Specific ways we prepare the table, fold the drapes, and words muttered under our breath. Not because we genuinely believe in spirits, but sometimes it feels like the room is listening. I reported the light to Biomed, and they conducted a full inspection the next day. No issues were found, not in the circuitry, wiring, or anything loose or burnt. They replaced the light just to be safe, but the report came back with no findings. I can't explain what caused it. Maybe a voltage irregularity, a brief fluctuation absorbed by the system, or something else entirely. But I do know this: the operating room teaches you humility. It constantly reminds us that despite our precision and training, we remain human, working in a space where life hangs in the balance between steel and breath, knowledge and instinct, and sometimes between the known and the mysterious. On that day, the light flickered, then it didn't, and sometimes that's all the explanation you'll ever receive. I'm grateful to all of you for accompanying me on these journeys. Your encouragement means a lot, and I enjoy reading your responses and personal stories in the comments. If these tales kept you captivated or sent chills down your spine, please press that like button and think about subscribing for more eerie stories. Have you ever faced something similar? Or do you have your own mysterious story to narrate? I would love to hear your insights in the comments below. Each of your experiences adds another dimension to our expanding community of horror fans. And if you believe someone else might appreciate a good fright, don't forget to share this video with them. Stay tuned for more hair-raising stories, and remember, sometimes the most frightening tales are the ones that could happen to any of us. Thank you once more for watching, and I'll catch you in the next video if you dare.